All right, so we're going to be starting the cardiovascular disorders in today's lecture. It's quite a long lecture, almost as long as neurology. Probably not quite as long. I would say this lecture will probably be an hour and 45 minutes, somewhere around there. So feel free to stop as we go at any point in time and, pick up at a later time. So we're going to be talking about, introducing cardiovascular disorders with some of the basic diagnostic tests that are routinely done. And then we'll talk about some of the generalized treatments for cardiovascular disorders. We'll talk a little bit about cholesterol and lipoproteins. Cholesterol gets a pretty bad rap. I'll try and put your minds at ease about cholesterol, but there is the potential for disorders to develop. So I want to just be clear about cholesterol and the development of vascular issues as it relates to it and the pathophysiology of it. We'll talk about some of the contributing factors of atherosclerosis. We'll talk about arteriosclerosis and atherosclerosis. They sound a lot alike. We'll talk about angina, angina pectoris, and MI, or myocardial infarction, which is also a heart attack. We'll talk about congestive heart failure, and we'll compare the differences in physiology behind left-sided and right-sided heart failure. So we'll have to do a brief review of the right and left side of the heart. We'll talk about something you probably never heard of before, rheumatic fever and rheumatic heart disease. Many of you have heard about rheumatoid arthritis and think maybe it's the same thing. So we'll talk about rheumatic fever and rheumatic heart disease. We'll talk about the pathophysiology of infectious endocarditis and pericarditis. If you remember back to anatomy and physiology, there's the endocardium, myocardium, and pericardium. So we'll talk about what can happen with infectious diseases of the inner part of the heart, the endocarditis, as well as the valves that are on the inside of the heart, and pericarditis, the outside. We'll talk about hypertension, primary and essential hypertension. We'll talk about PAD, the peripheral arterial disease or arterial peripheral vascular disease. We'll talk about aneurysms. We'll show you what they look like. And then we'll finish up with varicosity or varicose veins and thrombophlebitis. We'll mention phlebothrombosis, but I can pretty much guarantee you'll see a little bit more of the thrombophlebitis than anything, and probably varicosities, okay? Whew, that's a lot. I want to take a break at this point in time. Okay. So let's look at diagnostic tests and some of the general treatment measures. So one of the things that I'm sure you've heard of by now is something called an EKG or ECG for electrocardiograph. And this is useful in the initial diagnosis and monitoring of arrhythmia or dysrhythmia, MIs, myocardial infarction, infection, and pericarditis. Remember the EKGs? This is what would measure the P, QRS, and the T waves. Second, we could do auscultation. This is something that involves low tech and high touch. It's trying to determine if there's any valve abnormalities or abnormal shunts of blood that could cause murmurs. And the way this is done is non-invasively, cost efficiently, and all you need is a good set of ears, good hearing, and a stethoscope. Okay, and you place the stethoscope over different parts of the heart, and you can listen to the closure of valves. Remember, valves only make sounds when they close. Think of it as a clap, right? When you clap, it's the closing. Think of a door that closes. You hear the door slam shut, not so much slamming open. Okay, so auscultation is the art of listening to sounds through the stethoscope. Echocardiograph. This uses ultrasound. So it's used to record heart valve movements, it's used to record blood flow and cardiac output. Also pretty cost efficient. I have it done on many of my patients, and even when I go for routine heart checkups, they'll typically do an echo of the main arteries, the carotids and the vertebrals. Often they'll do an exercise stress test as well. And the way this is done is typically through a treadmill, right? Going on a treadmill, typically after someone is age 40 and older, they'll start to increase the speed and try and increase their heart rate. And at the same time, they're looking at their EKG readings, looking at all of the waves. Chest x-rays, believe it or not, you can see the heart. You can see the heart shadow on an x-ray, and you can see the size of the heart on an x-ray. Nuclear imaging, this uses a radiographic substance such as thallium, and it's very good to identify if there's any damage to the heart after a heart attack. Then there's a SPECT test. SPECT stands for single photon emission computed tomography. It's basically a CAT scan to assess ischemia. Cardiac catheterization, this measures the pressure and assesses the valves during heart function. Angiography, or an angiogram, this is going to visualize the coronary artery blood flow. And they can use an angiogram, which is to assess it, and they'll often use angioplasty, which I'll show you a picture of shortly, which could be used as a treatment administered if they happen to find any blockages. Doppler studies, these are basically like ultrasounds that assess the blood flow in the peripheral vessels. And they're able to record the sound of the blood flow and determine if there's any obstructions. Routine blood tests, these are pretty common. I run these just about on every patient that comes in. I'm curious about their triglycerides. I want to look at their cholesterol. And as I said in the opening, cholesterol gets a bad rap, and it really shouldn't. It's one of those controversial topics. If you look at the cell membranes, it's a large portion of the cell membrane, remember it's a phospholipid bilayer, is made up of cholesterol. When we look at your sex hormones, whether it's testosterone or progesterone or estrogen or aldosterone, those are all cholesterol based. If we look at the brain, it's 20-25% cholesterol. We need cholesterol. And when we stop the body's production of it, or we eliminate the liver's ability to produce it, it can create its own set of problems. One of the new black box warnings on some of the statin drugs, you'll hear me talk about statin drugs in a bit, one of the new black box warnings are dementia-like symptoms, because the brain isn't functioning very well without the 20-25% cholesterol that it needs. So in crisis situations, I can see using a anti-lipidemic medication or anti-cholesterol medication, but we're always talking about long-term complications of it. Keep in mind these medications are very, very useful in crisis care, life-threatening situations, but long-term, they all have their issues. Sodium can be checked. We know that there are people who are sodium sensitive. If they have too much sodium and they hold on to too much water, their blood pressure could go up. Potassium is like the anti-sodium. So we want to check sodium and potassium together Usually, from what I have found, I don't find too many sodium issues. What I find is too little potassium issues. So if you have too little potassium in relationship to sodium, sodium wins and blood pressure goes up. We want to have a good amount of potassium to counteract sodium's effect. Calcium, we want to check other electrolytes, homocysteine levels. Remember I said high homocysteine levels are like liquid sandpaper running through a blood vessel, and it can really damage them. And we'll go over some of the physiology or pathophysiology of what happens to the endothelial layer when those epithelial cells get damaged. You've heard of CRP, C-reactive protein, and there's something called high sensitivity, HS, high sensitivity CRP. This is specific for cardiovascular issues. CRP is generalized for inflammation. High sensitivity CRP is pretty specific and predictive of a cardiovascular event that may happen. So I like to run that on many of my patients. ESR, the erythrocyte sedimentation rate, not just HDLs and LDLs, which is the cholesterol panel, but I like to look at oxidized LDLs. These are LDLs that are damaged, right? LDLs, we need them. Even though LDL has a bad rap, they call it the bad cholesterol. But then again, having your liver manufacture LDLs are needed for cells, for the brain, for all your sex hormones, testosterone, progesterone, estrogen, aldosterone. It's if you have these LDLs and you have a poor lifestyle. So if I'm a smoker, the LDLs get oxidized. If I drink alcohol, the LDLs get oxidized. If I exercise intensely, exercise by itself creates a lot of oxidation because of the increased work of the mitochondria. The LDLs get oxidized. This is why antioxidants are so very, very important to try and negate this damage. The more oxidation, the more potential that the LDLs become damaged. And that's really a problem that we need to focus on. Troponins, these are enzymes released from cardiac muscle when there's damage. So if someone's in the process of having a heart attack, not even having one, but just before, these can be released early on. So troponins could be predictive. It can tell you if they have one, if they're having one, or if they had one and they're in the recovery phase. They could also look at the arterial blood gas. That can check the current oxygen levels and even the acid-base ratio. General treatment measures. Okay, generally speaking, what can happen? Dietary modifications to decrease total fat intake. And again, this is one of the controversial topics about fat intake. There are many people that are on high fat diets and low carbohydrate diets. It really depends on your genetic makeup. There are some people who can metabolize and break down fat very well. There are some people that metabolize carbohydrates very well, and some that can metabolize and break down proteins very well. So unless you have a full genetic workup, you really don't know in terms of your diet how much of it should be carbohydrate-based, fat-based, and protein-based. There are general rules, but then again, we're all made up a little bit different. Some people drink and need lots of water. Some can survive on very little water. Some can tolerate high intensive exercise. Some can't. We're all a little bit different. General weight reduction, and I want to stress, it's not weight. It's not stepping on a scale and seeing 200 pounds or 250 pounds or even 300 pounds. We're looking at the weight in terms of body composition. Get one of more of the advanced scales. What I do in my office on my patients is I put these electrodes, I put 2 on the feet and then I put 2 on the hands, and I do a BIA on them. I do a bioelectric impedance analysis that measures what the percentage of water is, what percentage of water is inside the body, outside, inside the cell, outside of the cell, what their lean mass is and fat mass in both percentage and weight. And we want to see a shift in body composition where we want to increase muscle mass and we want to decrease fat mass. Okay? The more muscle mass we have, the more mitochondria. That's called mitochondrial biogenesis. And the more mitochondria they are, the more they will be looking for triglycerides and fat to metabolize for fuel. So you increase muscle mass, decrease fat mass, guess what happens to a scale initially? The scale can go up. And this is what happens to a lot of people initially when they start training or going to the gym. They go, I've been exercising and oh my God, I gained 3 pounds. Well, you're a healthier individual if the 3 pounds was because of muscle mass increase and a decrease in fat mass. So keep that in mind with weight reduction. We really want to think more of body composition and fat mass versus lean mass. Reducing salt intake. This too is controversial. If you think of how many years, and I can tell you I've been in healthcare for over 25 years, we've been talking about decreasing salt, decrease salt, be careful with salt, and yet cardiovascular diseases have been going up. And I have seen in my office many cases through the years where people have needed to increase salt intake because of their cardiovascular issues. So again, I don't really see it as much as a increased salt and sodium issue that's a problem as much as I've been seeing a decreased potassium issue. Regular exercise is important. Now, for each person, some people need low intensity, some high intensity, some a combination of both. You have to do it and then say, how do I feel afterwards, right? Just like after you eat a meal, how do I feel after the meal? That could pretty much tell you, is this healthy or unhealthy for you? How do you feel after the exercise? Do you feel healthy or not? And I can tell you years ago when I was training very, very intensely, I was becoming exhausted. And I did some advanced testing and I ended up finding out that my body needed more low intensity training, and 1 to 2 training sessions out of 10 could be high intensity, but the majority of them needed to be at a lower heart rate. So instead of getting my heart rate up at between 140 and 150, having it somewhere around 126 to 128, my body does a lot better with that. Otherwise, when you're under stress, you can push out too much cortisol, and we know cortisol is very harmful to the body. But we do know that exercise is important. It can help to increase your HDLs, your high density lipoproteins. The HDLs have the good reputation. They help take all the excessive LDLs and bring them back to the liver, right? LDLs go from the liver to the cells and tissues. HDLs take the excessive ones from the cells and tissues and puts them back in storage into the liver. Trying to decrease smoking. Smoking has an effect of vasoconstriction on the body and on the blood vessels, I should say. And if you vasoconstrict the blood vessel, then blood pressure goes up. If you quit smoking, you certainly decrease the risk of coronary artery disease, CAD. The general treatment measures are vasodilators. When you consume a vasodilator, it helps to reduce peripheral resistance. When there's more resistance in your blood vessels, blood pressure goes up. If you dilate blood vessels, that decreases the resistance, and then blood pressure goes down. Beta blockers. Beta receptors are part of the sympathetics. It's part of the fight or flight response. So we have these fight or flight receptors, and if you block those beta receptors with beta blockers, then it really helps people who have angina attacks, which is chest pain, and it can really treat their arrhythmia or dysrhythmia and hypertension. Calcium channel blockers. Calcium makes muscles contract pretty hard. So if you take a calcium channel blocker, I can tell you that magnesium is like a natural calcium channel blocker. It decreases the cardiac contractility. What else? Antihypertensive and vasodilators are also other medications that are helpful. And they tend to be prophylactic against angina, kind of like preventative measures. Okay, so calcium channel blockers decrease the cardiac contraction. If you decrease the amount of calcium rushing into a muscle cell, it doesn't contract as hard. Calcium channel blockers act as vasodilators and antihypertensives. And again, they are prophylactic against angina pectoris or chest pain. Digoxin, this is used to treat heart failure. Antihypertensive medications are used to lower blood pressure. Adrenergic medications, they act on the sympathetic neural system. And then we have ACE inhibitors, angiotensin converting enzyme inhibitors. What does angiotensin converting enzyme, what does this enzyme do? Well, naturally in the body, it converts angiotensin 1 into angiotensin 2. And this enzyme, angiotensin converting enzyme, or ACE, this is released from the lungs. And angiotensin 1, which is in circulation, hits the lungs, and it converts angio 1 into angiotensin 2, and angiotensin 2 is a vasoconstrictor. So if you block angiotensin 2, then you don't get hypertension. What else can be used? We have diuretics, right? Think of it, alcohol is a diuretic, coffee is a diuretic. So diuretics help remove excessive sodium and water, and it's used to treat high blood pressure and CHF, congestive heart failure. One of the big diuretics out today is called Lasix. The problem with diuretics, I've seen quite a few studies on this, when you remove water, minerals follow. And when you lose potassium, all the other minerals follow. If you lose potassium, then you lose magnesium, and then you lose sodium, and you lose all these other electrolytes. When you lose electrolytes, you start to get the improper firing of nerves and muscles and diaphragm, and things start to malfunction internally. The organs start to malfunction. So when people are on long-term diuretics, they get what's called ectopic contractions, or ectopy. It's called ventricular ectopy, where you get these irregular heartbeats, and the heart just stops. It just stops, and the people die. So we have to be very, very careful with some diuretics. You'll see that now some of the diuretics are called potassium sparing to try and limit the severe adverse reactions. The problem with the potassium sparing diuretics is they don't work as effective. The ones that work obviously have more adverse reactions. Anticoagulants. These reduce the risk of blood clot formation, right? Anticoagulation. Heparin, warfarin, aspirin, high-dose garlic, vitamin E, red wine, resveratrol. These are all have anticoagulant capability. I'm not saying to do all those things at one time. It's excessive, but they all thin the blood. Let's put it that way. Cholesterol-lowering drugs are called statins. some on the market. Let's see, simvastatin, arthrostatin. These statins are Lipitor, Crestor. These are statins that block the body's ability to produce cholesterol. It blocks an enzyme called HMG CoA reductase. HMG CoA reductase is needed in the cholesterol pathway. So if you want to research and look at a good image of the cholesterol pathway, you will see HMG CoA reductase, and you'll see the statin blocks that. The problem with this, look, there's benefit. You don't produce cholesterol. So those that have a lot of oxidation in their body, then we want to limit the cholesterol production. However, there's some adverse reactions to it. When you look at that flow chart of cholesterol production, when you Google it or research it, you'll see that besides cholesterol, the body makes squalene, which is another antioxidant for the eyes and the skin. But it makes another coenzyme called coenzyme Q10. And CoQ10 is needed for energy production. It's needed by the electron transport chain. Remember, first we have glycolysis, which takes glucose and breaks it down to pyruvate or pyruvic acid. And in the presence of oxygen, pyruvate can enter the mitochondria from the cytoplasm. And now you have the Krebs cycle, which is dependent on your B vitamins, B1, B2, B3, and lipoic acid. And the byproduct of that is a lot of coenzymes, NAD, NADH, and FAD or FADH. And the exhaust, besides those coenzymes, are carbon dioxide, which is what we exhale. You breathe in oxygen, and then you exhale CO2. That's from the Krebs cycle. That's why it's called cellular respiration. After the Krebs cycle, those coenzymes are used in the electron transport chain, the ETC. And there are these iron sulfur boxes that are there. That's why we need iron. And when you're iron deficient, you have no energy, fatigue. But CoQ10 is also needed. If you look at the electron transport chain, you'll see CoQ10, coenzyme Q10 is needed. It helps to transfer the electrons. I believe I think there's 5 little channels in there. I think it's from between channel 2 and 3 is where CoQ10 comes into play. All right, so statins block CoQ10 production. We need CoQ10 in order for the electron transport chain to make ATP efficiently. So what happens? You're taking the cholesterol medication, you're taking the statin, you decrease the amount of CoQ10, the mitochondria can't make ATP, the body starts to cry in pain. Well, what parts of the body cry in pain? The parts of the body that need the most mitochondria. What are the parts of the body that need the most mitochondria? Parts that are working all the time. How about your muscles? So when muscles cry in pain, you get myalgia. Remember fibromyalgia? So muscles start to ache. Your joints ache. They call it arthralgia. Nerves ache. It's called neuralgia. Anytime a word ends in algia, it's pain. Neuralgia. Remember that the outside of most neurons are myelin, which is cholesterol. It's fat. So the domino effect to this gets pretty bad. So keep that in mind. There are many times that I've had where patients came in with myalgia and arthralgia. They thought it was structural, and it wasn't. It was chemical. And when I sent them back to their primary healthcare physician and let them know that they were having a myalgia and arthralgia secondary to the statin, they took them off that drug immediately. Okay, so these are some of the names of the medications. It tells you here what they're used for. It tells you the action. So nitroglycerin, this is what people put underneath their tongue if they're having an angina attack where they have chest pain, and it is a very strong vasodilator. Uh, Metropolol, or Lopressor. This one here is used for hypertension, angina, and a antiarrhythmic medication. The Metropolol, this is a beta blocker. When we look at um, enalapril or Vasotac, this one's for high blood pressure or hypertension. This one here is the ACE inhibitor. So this is the one that blocks angiotensin 1 to be converted into angiotensin 2. Then we have furosemide, which is Lasix. This one is used for the edema, or swollen ankles, that's associated with hypertension. This is your diuretic. The problem with it, we know, well, not the problem, it will increase the excretion of water and sodium, but there's a lot of neurological effects that can happen from this. Then we have the statins, which is Zocor. This is used for hypercholesterolemia. This one's going to decrease cholesterol and LDLs. And besides the digestive discomfort, we're looking at musculoskeletal neurological side effects due to decreased CoQ10. Warfarin, this is Coumadin. This is your blood thinner. It's an anticoagulant. It's going to interfere with the function of vitamin K. Vitamin K for coagulation, for blood clotting. Warfarin was used primarily, it was a rat killer, believe it or not. They used to use warfarin to kill rats. Rats would consume it, and they would die upon consumption from internal bleeding. And they figured, well, if we could dose this properly and give it to humans without killing them, let's use it just to thin the blood without having all the severe reactions. Okay? And then aspirin is also a very big blood thinner, but you have to be careful due to the gastric irritation with it. And we know never to give aspirin to young kids and babies that have a virus because of Reye's syndrome, R-E-Y-E-S. Okay, if you need to pause here, you can. If you need to, if you're okay and you want to keep going, it's fine. We've been going about 30 minutes, so we're going to keep going here. Let's look at some of the coronary artery disease. We'll compare and talk a little bit about arteriosclerosis and atherosclerosis. We'll talk about angina, which is the chest pain, and we'll talk about MIs, myocardial infarction, or which is a heart attack. So arteriosclerosis, you should know that this is the generalized term for all types of arterial changes. It's a very generalized term. Degenerative changes in small arteries and arterioles. In terms of arterial changes, there could be the loss of elasticity. Remember, blood vessels are made of collagen, but also elastin. So when the blood vessels need to dilate to lower blood pressure, they can, and when they need to recoil back and constrict to increase blood pressure, they can. The lumen can gradually narrow and can be obstructed. And when that happens, then we have increased blood pressure. Now, atherosclerosis is the presence of an atheroma in large arteries. These plaques consist of lipids, calcium, and possibly clots as well. And I'm going to show you the process of atherosclerosis. Right here, we see that this is an angiogram, and you can see that this coronary artery is nice and open. But right here, it's open, and then you see something blocking this artery. So this is where they would need to put a stent in there to open that up. Lipid transport. All right, let's talk a little bit about cholesterol. So lipids are transported in blood by attaching them to proteins. So we call them low density lipoproteins. Those are the LDLs. And then we have HDLs, which are the high density lipoproteins. So the low density lipoproteins, as I said earlier, they transport cholesterol from the liver to the cell. Now, when does the body do this? Primarily at night. In the evening is when the liver makes these LDLs, which is why most people take their anti-lipidemic medication. They're instructed to take it in the evening. And believe it or not, many people don't follow these instructions. They take it in the morning, but the half-life of the drug wears off, and then their cholesterol continues to go up. So when they go back to the doctor and they check their lipid levels and cholesterol levels, they go, the medication's not working. They never asked them if they were taking it properly, but usually most pharmacists will tell and instruct them to take it at night. The major factor contributing to atheroma is the formation when the LDLs are oxidized. So we call it oxidation. So you need two things. Primarily, you need LDLs in high amounts, and then the poor lifestyle choices and habits which oxidize them, and that starts the pathophysiology of these blocked arteries. But they don't really happen by accumulating in the lumen. It usually happens in the outer layers, pushing inward, blocking the lumen. All right, the HDLs transport cholesterol away from the peripheral cells back to the liver. Those have the reputation of being the good lipoproteins. Okay. So I wanted to show you a normal artery here on the left-hand side. Let's review some of the basic anatomy to an artery. So the inner lumen, if we look here, here's the inner lumen. It is simple squamous cells. You see how it's one cell layer thick. That's the endothelium, but it is simple squamous epithelium, one cell layer, so this layer can be damaged easily. That's also known as the tunica interna or tunica intima. Then, deep to that, we have the smooth muscle. That's the tunica media or the tunica musculosa. This is the layer around here that can vasoconstrict or vasodilate. And then we have the external layer, which is the tunica externa. This is the elastic layer here, also known as the tunica adventitia. All right, so how does the accumulation, how does this artery become blocked? Look, it's nice and smooth. So what happens is the endothelium in here gets damaged somehow. And we do have cholesterol that gets into the deeper layer, right? It breaks through the damaged endothelium, breaks itself, the cholesterol gets into the smooth muscle down in here. Now, monocytes, which are in circulation, break in as well. They break through the damaged endothelium, and they find the cholesterol, the LDLs, that become damaged. The monocytes are now called macrophages, but the exact macrophage is referred to as a foam cell after it engulfs the oxidized LDL. It's called a foam cell. And then you start to get an accumulation of lipids, calcium, cellular debris, an accumulation of all of these foam cells start to build up and create a hill. In here, in the smooth muscle layer, it's deep. And as it starts to build up and build up and build up, look what it does to this endothelial layer. It starts to push it up like a mountain, like a hill. So as blood is coming through now, you see it's open here. As it comes through here, it becomes constricted, okay? It becomes turbulent. And as the body perceives that blood flowing through here in a turbulent manner, your body thinks you got shot or stabbed and that you're losing blood turbulently. So the body starts to convert fibrinogen into fibrin, and you get this fibrous clot. And it keeps on working as a positive feedback loop where it keeps, clotting and clotting and clotting until no blood gets through the area. And if it happens in a vertebral artery or a carotid artery going into the brain, we call it a stroke. If it happens to the heart, we call it a heart attack. Okay? So hopefully this image gives you a much better understanding of how atherosclerosis and clogged arteries happen. Most people think it happens in the lumen, like cholesterol is roaming around in here and it starts to create a buildup on the inside. No, 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 no. It's here and it starts to push. In fact, if you have high blood pressure and that damages the endothelium, again, if this layer breaks, your body is going to use cholesterol to patch this up. It's going to use cholesterol as a fixer-upper. So high cholesterol is sometimes an indicator of endothelial cell damage in blood vessels, and your body is increasing the cholesterol to fix it. When you have high pressure hitting these walls, it breaks it down, and that can become a problem. Okay? So then what'll happen, you see here, they put this catheter through, right? And it's like a balloon, and then around the balloon is a stent. They inflate the balloon, the stent opens up, they remove the balloon, they deflate it, and then you're left with this patent or open stent. Okay? So this is the treatment when you have this accumulation of plaque deep underneath the endothelium, but superficial, right, to the smooth muscle layer. All right, it pushes up and creates a mound or a hill. All right, so that visual, I hope that helps, right? And it keeps it nice and open. And here, if you look, this is the lumen. This is what's open. This is all accumulation of plaque, oxidized LDLs, right? This lumen should be this big. This is what's left of it. This is where all the accumulation is, and it starts pushing in this direction, making this narrower. Okay, so what are some of the risk factors? Some are non-modifiable, some you can modify. So the non-modifiable, you can't change your age, gender, genetic or familial factors. These are somewhat inherent. Modifiable, obesity, sedentary lifestyle, cigarette smoking, alcohol, fried foods, all of these things can oxidize the LDL. Diabetes mellitus, this can damage blood vessels. Poorly controlled hypertension. The combination of the OC, the oral contraceptive, and smoking, double whammy. Very, very dangerous. Some of the diagnostic tests, just checking for a lipid panel, stress testing, and even nuclear medicine. So what are some of the generalized treatments for atherosclerosis? Again, here's the term weight loss. What we really need to focus on is comparing muscle mass to fat mass here. When you increase exercise, you increase muscle mass, weight will go up, but it's healthier. Fat cells release inflammatory cytokines, dangerous. Muscle mass, much healthier. The more muscle, naturally the mitochondria are going to look for fuel, and they burn fat for fuel. Lower the total serum cholesterol and LDLs by dietary modification. Stay away from all the fried foods. Reduce the sodium intake if you're salt sensitive. Some people can tell right away. They consume something with salt, they drink water, and they can feel their blood pressure go up right away. control the hypertension by decreasing inflammation. What I have found on my patients, when I take blood pressure, I use blood pressure as an inflammatory biomarker. When I see it's high, I say, okay, let's focus on decreasing, let's put out the fire in your body. Let's see if we can get away some of that inflammation. And we do so with some anti-inflammatory vitamins, some herbs, and focusing on an anti-inflammatory diet. And typically, within 2 to 3 weeks, we see blood pressure decrease. They are extremely happy. Why? Because they didn't have to use any medications. Okay. Quit smoking. The anti-lipidemic drugs are also helpful, but you have to be aware and know what their adverse reactions are. And also be aware of the DINs, the DINDS, the drug-induced nutrient depletions. The ones with statins happen to be the coenzyme Q10, so that must be supplemented to try and limit the arthralgias, the myalgias, the neuralgias, and the energy reduction. Surgical intervention, such as coronary artery bypass, is obviously a much more invasive procedure, but necessary in a crisis care situation. Okay, so let's look at the different degrees of atherosclerosis. Now, keep in mind, this could be a little bit tricky, right? This is a clear artery. This is a partial obstruction. But you see this yellow? Remember, based on the picture I showed you before, it's not that the accumulation is in the lumen, it's outside pushing in. Okay? So when you have a complete, let's say a partial blockage to a coronary artery, you get decreased oxygen to the tissues, you have ischemia. You get ischemic heart disease, and that shows up as angina pectoris, which is chest pain, cramping of the chest. If it's a total occlusion, then you have the heart attack. That's the MI, the myocardial infarct. Myo is muscle, cardium for heart. In the brain, if it's the carotid arteries or cerebral arteries or vertebral arteries, and it is partial, you get a TIA, a transient ischemic attack. If it's total, that's the stroke, the CVA, cerebrovascular attack. If it's in the aorta, you can have an aneurysm where it becomes occluded or it starts to bow outward. It expands a bit, and in very extreme cases, it can rupture or hemorrhage. Okay. The legs, you can get peripheral vascular disease. It shows up with decreased hair on the lower leg. You can get different coloration and gangrene, and in extreme situations, amputation. So angina pectoris, this is when there is a deficit of oxygen to meet the heart's needs. And this shows up with chest pain, right? The classic angina or exertional angina, this is when grandpa would go outside, or dad, if it was a little bit older, right, with poor lifestyle habits, who would shovel and then he would pause and grab his chest. That's classical or exertional. The chest pain or the angina in the pectoral region only happens on exertion. Now there's variant angina, which happens from a blood vessel spasm, and that can occur at rest. The ones that are very unpredictable are these unstable anginas. This is prolonged pain at rest. Okay, imagine not doing anything, and that's when this comes on. Happening during exertion, that's predictable, but when you're not doing that, that's really unstable. And this may precede the heart attack, the myocardial infarction. So what's some of the etiology of angina? It's things that are going to create insufficient oxygenation in arterial blood. Arterial sclerosis, atherosclerosis, vasospasms, and even myocardial hypertrophy, meaning the heart size increases and the chambers decrease in size as the muscle thickens. Severe anemia due to decreased oxygenation, and even respiratory diseases. Activities which increase the demand for blood, exercise, that could be another cause. Emotional stress, a respiratory infection with fever, exposure to extreme weather patterns, pollution, and believe it or not, even eating a large meal. This happens to a lot of people after they eat a large dinner. Keep in mind, blood is then diverted into the GI tract for absorption, and it's diverted away from the heart. So you have decreased oxygenation to the heart after a meal. What are the clinical manifestations of angina? So typically recurrent, intermittent, brief episodes of substernal pain triggered by physical or emotional stress. The pain is described as a tightness or pressure. Tightness in the chest. The pain can radiate to the left arm and the neck. There's pallor, there's diaphoresis. Remember, diaphoresis means they're sweaty and they're nauseous. The attacks can vary in severity and duration, but become more frequent and longer as the disease progresses. So it's intermittent, brief episodes of substernal chest pain that's triggered by physical or emotional stress. They have this tightness in the chest, pressure on the chest. It radiates down the left arm. They're sweaty, nauseous, and pale. What do they do for this? Well, stop right away, rest. If the patient is seated, make sure they're seated and in an upright position. You can give them nitroglycerin, or they typically have it on them. They put it underneath their tongue. Sublingually, it gets into circulation pretty quick, and it acts as a vasodilator, so it gets oxygen into the tissues right away. Okay. Now, MI, myocardial infarction. MIs occur when the coronary artery is totally obstructed. It results in cell death of the heart wall, and atherosclerosis is the most common cause of an MI. The infarction may develop in three different ways: a thrombus from an atheroma that can obstruct the artery, a vasospasm that's in the presence of a partially obstructed blood vessel, or an embolism, which is a thrombus that travels. In terms of the pathophysiology, there are cardiac enzymes that are diagnostic that are released into the tissue fluid, and blood troponins. If the blood supply is restored within 20 to 30 minutes, the permanent damage can be prevented. If the blood supply was not restored, then the opposite, right? You get fibrous tissue that replaces the cardiac tissue. And remember, these troponins, these could be an early indicator. If these are picked up in blood, they could say, well, you've had a heart attack, or, you're about to have one, or, you're in the recovery phase. And they can tell how severe a heart attack a person had. What are some of the warning signs? Feeling of pressure, heaviness, burning in the chest, shortness of breath, just weakness, tired, nauseous, indigestion. Believe it or not, a lot of people have heartburn. They feel they have heartburn, and that is one of the early warning signs. So when they have heartburn, and then they have that diaphoresis, and then they're weak and they're tired, and they have this anxiety, this feeling of impending doom, that's usually an indicator of a heart attack. The hallmark for a heart attack or an MI is the sudden substernal chest pain that radiates to the left arm and shoulder or jaw. But they typically describe it like they'll clench their fist and hold it up to the chest. It's almost like the universal sign of a heart attack. They clench their fist, hold it up to their chest, and to them they say it feels like an elephant is sitting on their chest. That's how heavy it is. It's severe, it's steady, It's crushing pain, and there's just no relief. There's no relief of pain or with vasodilators. So again, sudden substernal chest pain, it radiates in the left arm, shoulder, or jaw, and they feel like it's an elephant that's sitting on their chest. Severe, steady, and crushing, and even the vasodilators don't help. There is a silent myocardial infarction. There's no pain. The patient may experience some GI discomfort, more common in women than in men. Again, pallor, diaphoresis, the sweating, nausea, dizzy, weak, difficulty in breathing, dyspnea, anxiety. Remember, they have this impending feeling of, fear and death is coming upon them, hypotension, and a low-grade fever. This is all seen with MI. Some overlap with angina as well. There will be changes in the EKG. There will be serum enzymes and the isoenzyme levels. There will be serum level of myosin, and the cardiac troponin are going to be way, way high. There'll be leukocytosis, elevated CRP, C-reactive protein, but also the high sensitivity CRP, as well as the ESR. They'll be checking their arterial blood gas measurements that can be altered, and they'll also check the pulmonary artery pressure. Some of the complications. Sudden death is often the first symptom. My father happened to die this way at the young age of 44, pretty young guy. Woke up in the morning, just didn't feel too well, went to his doctor, was given a clean bill of health, and about 7 or 8 hours later, he was dead. So I know firsthand that oftentimes the first symptom can be death because it happened to him. Heavy smoker, didn't eat, a lot of fast food, the lifestyle. He was a New York City police officer in the early 70s to mid to late 80s, stressful life, just, very, very unhealthy. So all the cholesterol that he had oxidized from all the smoke, all the fried food, and it had to have been just a massive thrombosis, they said, that blocked his artery. But never had any symptoms. That was the first one. Okay, so sudden death, it's often the first symptom. Cardiogenic shock, congestive heart failure, rupture of the necrotic heart tissue, and a thromboembolism causing a stroke, right? Cerebrovascular attack. So you can have a thrombosis and it releases itself and it starts to travel and it gets caught in a smaller blood vessel. The treatment, reduce the cardiac demand, relax, chill out, don't do anything super stressful. Oxygen therapy, analgesics, anticoagulants, thrombolytic agents, tissue plasminogen activator. All these things keep the blood thin and break up any clots. Medications to treat any dysrhythmia or arrhythmia or hypertension or CHF, congestive heart failure. And then rehabilitate. Cardiac rehabilitation starts right away. Many cardiologists even have a rehabilitation center within their cardiac facility. Okay, everyone doing good? I know there's lots of information. We're just a little bit less than an hour. You guys are doing really, really good. Let's look at cardiac arrhythmias or dysrhythmias and congestive heart failure. So let's just do a brief review of some of the basic anatomy of the heart. Here is the right atrium, right ventricle, left atrium, left ventricle. Here's the aortic arch. Here's the pulmonary trunk. Here's the superior vena cava. So the superior vena cava is bringing the deoxygenated blood from the head, the neck, the brain, right and left upper extremity into the right atrium. And then underneath here, we really can't see it, but that would be the inferior vena cava, bringing blood from the entire lower extremity. So keep in mind, if there's a blockage going on anywhere in here, it can create this backflow of fluid into the upper extremity, or a backup of fluid into the lower extremity. Okay, let's look at the left atrium and left ventricle. After blood goes from the right atrium into the right ventricle, it pumps it into the pulmonary trunk, into the pulmonary arteries. These pulmonary arteries are blue because they carry deoxygenated blood. It's going to pump, here's the left pulmonary artery, it's going to pump deoxygenated blood into the left lung, oxygenates it, and tries to push it back into the left atrium. The left atrium receives the oxygenated blood, pumps it into the left ventricle. The powerful, strong left ventricle pumps it through the aortic valve into the arch of the aorta, into these blood vessels that pump it into the, into the arm, into the left or right side of the brain. Then it goes down into the thoracic aorta, to the abdominal aorta, and down into the lower extremities, and pumping all the oxygenated blood into the entire organs, the liver and the kidneys and all of the muscles. Okay, so that's part of the physiology. The other part is this conduction system. What makes the heart contract is the SA node relaying that electrical current to the atrioventricular node. And then, remember, the atriums contract from superior to inferior. It pumps blood and uses gravity to pump it down into the ventricle. But when the ventricles contract, they pump blood inferior to superior. And the way that happens is that the heart has to contract down below first before these cardiomyocytes contract. And the way that happens is that the electrical current is hidden in the interventricular septum. So after the AV node, you have the bundle of His, right? The AV bundle of His, which eventually divides into a left bundle branch and a right bundle branch. And then the right bundle branch has its Purkinje fibers that inject themselves into the muscles of the endocardium. And then the left bundle branch divides into these Purkinje fibers that drive it into the left side of the endocardium, into all these papillary muscles, and make it contract. So the electrical current gets all the way to the bottom and outside, and it makes this pump from inferior to superior. It makes this pump inferior to superior to make sure that when the ventricles contract, it pumps it up into the aorta or pumps it up into the pulmonary trunk. Make sense? Okay, so when we get into some of the conduction issues, well, maybe there's a blockage in the left bundle branch, the right bundle branch. Maybe there's an AV blockage, an SA blockage. They need to put a pacemaker in, which goes here. All right, so when you hear of these blockages, we're not necessarily always referring to blockages in blood vessels. Sometimes there are blockages in the conduction pathway. When we look at conduction, we can measure this. This is the electrocardiograph. We're measuring with the PQRST waves. We're measuring with the P wave atrial depolarization, which is contraction. And then the QRS wave, we're measuring ventricular contraction or ventricular depolarization. And then the T wave is the ventricular repolarization, the resting phase. So depolarization is always contraction, repolarization is the relaxation phase. Okay, so cardiac dysrhythmias or arrhythmias, this is any deviation from normal cardiac rate or rhythm. It's caused by an electrolyte abnormality. Big. This is why I say, be careful when you talk about eliminating salt from the diet. Be very, very careful with that. What else can create it? Hypoxia, stress, infection, drug toxicity, and even fever. Electrocardiography. This is used for the conduction for monitoring the conduction system that we just showed you before. It can detect any abnormality. Reduction of the efficiency of the heart's pumping cycle, right? So dysrhythmias could be a real big problem. So there's a lot of different types of abnormal conduction patterns that exist, and understanding the PQRST waves and having a cardiologist understand this is important. Okay, if you're getting into heart health and you plan on working in a cardiac office or in a hospital, and you want to help rehabilitate patients with cardiovascular issues, it's really important to understand some of this. So the SA node is the pacemaker of the heart. The rate can be altered. When you hear the term bradycardia, this means that it's a regular heart rate, but it's just a little slower. It's less than 60 beats per minute. Tachycardia is a regular rapid heart rate between 100 and 160 beats per minute. When there's a sick sinus syndrome, this is marked by altering between bradycardia and tachycardia. And when you have this is typically going to require a mechanical pacemaker. A mechanical pacemaker here, which is the SA node, which sets the pace to the heart. Okay, atrial conduction abnormalities. Let's see, premature atrial contraction or beats. These are PACs or PABs. There's an extra contraction or ectopic beat. You heard me use this word before, ectopy, when I talked about Lasix and diuretics, that there were people who would die from these ectopic, ventricular ectopic contractions. Atrial flutter. This is when the atrial heart rate goes from 160 to 350 beats per minute. I mean, that's a flutter, okay, right? The AV node delays conduction, so the ventricular rate is slower. Now, what's more common that I'm sure many of you heard is AFib. AFib is atrial fibrillation. This is when the rate is over 350 beats per minute. It causes pooling of blood in the atria, and you're at a risk for a thrombus formation, okay, because you have pooling of blood in those chambers. Okay, AV node abnormalities, the heart blocks. The conduction excessively delayed or stopped at the AV node or the bundle of His. So AV node or bundle of His. Here, the AV node or the bundle of His. So somewhere in here, there could be let's go back. Conduction is excessively delayed or stopped at the AV node or the bundle of His. Now there's a first degree block, second degree block, and third degree block. Remember, these blocks are not related to vasculature here. They're not related to blood vessels. It's the conduction. So the first degree block is a conduction delay between the atrium and the ventricle. A second degree block, every second to third atrial beat is dropped at the AV node. And a third degree block, no transmission from the atrium to ventricles at all. Now the ventricular conduction abnormalities, this is the bundle branch block. So let's go back here. The bundle branch, which is either here or here. So that interferes with the conduction in one of the bundle branches. That can lead to ventricular tachycardia, likely to reduce the cardiac output as reduced diastole occurs. Ventricular fibrillation, where muscle fibers contract independently and rapidly, and the cardiac standstill occurs if not treated immediately. Then there's premature ventricular contractions, where there's additional beats from ventricular muscle cells or an ectopic pacemaker, and that may lead to ventricular fibrillation. Okay, so here are some of the terms: bradycardia, tachycardia, atrial flutter, fibrillation. Um, those are some of the biggies that I think you should be a little bit familiar with. I'm not going to ask you much on these QRS and these bundled branch blocks. I'm not going to ask you too much on that, if anything at all, nothing. Cardiac arrest. Okay, what is cardiac arrest? That is the cessation of all heart activity. There's no conduction of impulses, and there's a flat EKG or ECG. So, what are some of the reasons for cardiac arrest? Excessive vagal nerve stimulation. What is the vagal nerve? It comes from the medulla. It's cranial nerve 10. It is parasympathetic, and it's inhibitory. Potassium imbalance, cardiogenic shock, drug toxicity, insufficient oxygen, respiratory arrest, and even a blow to the heart, right? Some sort of impulse or shock to the heart. Very, very dangerous. The cardiac dysrhythmia, the cause needs to be determined and then treated. They typically use these anti-dysrhythmic drugs. They can use an SA nodal problem, and they can replace that with a pacemaker, or they can even use defibrillators, can be implanted for the conversion of the ventricular fibrillation. Okay, so CHF, congestive heart failure. This is when the heart is unable to pump out sufficient blood to meet the metabolic demands of the body. Again, congestive heart failure is when the heart is unable to pump out sufficient blood to meet the demands of the body. Usually a complication of another cardiopulmonary condition. It can involve so many different factors. There are various compensatory mechanisms that maintain cardiac output, and some of these often aggravate the condition. So when the heart cannot maintain the pumping capability, then now you've got cardiac output that's decreased. When you have cardiac output that's decreased, you can't maintain the pumping capability. You got stroke volume that decreases. If you have cardiac output or stroke volume that decreases, you have less blood that's going to reach all the organs. If you have decreased blood and decreased oxygen, you're going to have decreased cell function. The mitochondria need oxygen. You're going to have fatigue and lethargy, and mild acidosis develops because those cells are going to die, releasing all the acids from inside the cell. All right, so now we're going to get, with the pathophysiology, there's going to be this backup and congestion that develops as coronary demands for oxygen and glucose are not met. The output from the ventricles are less than the inflow of blood. The outflow from the ventricles is less than the inflow of blood. The congestion in the venous circulation draining in the affected side of the heart. I got to show you a picture to help you understand this. Okay, let's take a look. But some of the causes are the CAD, post-infarction, conduction issues, valvular problems, pulmonary diseases. All of these can create congestive heart failure. What are the clinical manifestations? With the forward effects, which are similar with the failures either on the left side or the right side of the heart, there's going to be decreased blood supply to the tissues. There's going to be hypoxia, fatigue, weakness, difficulty in breathing, shortness of breath, and the compensation to this is going to be increased heart rate, right, to try and get more blood and oxygen to the parts of the body. Cutaneous and visceral vasoconstriction. It's going to shunt blood from all of the peripheral parts of the body and try and keep it near the core. and then daytime oliguria, which is low urinary output. All right, let's look at left-sided heart failure, and then we have a picture to show the left side of the heart. And then we'll look at right-sided heart failure, and then we'll have another picture showing the right side. So let's go back here. Left-sided heart failure is related to pulmonary congestion, dyspnea, orthopnea, which is just difficulty in breathing, primarily at night when you're lying down due to all of the accumulation of blood in the lungs. It's going to result in cough from the fluid that's irritating the respiratory passages. There's going to be paroxysmal nocturnal dyspnea, which is just abnormal breathing patterns at night. And it's going to indicate acute pulmonary edema. Usually develops during sleep. You have excessive fluid in the lungs, and it frequently results in infections such as pneumonia. So if we look at the right side of the heart, when you see these squiggly lines here, it means that there's less blood here. So if there's less blood that's coming out here, we have this, as a result, the cause of this less blood. Let's start there. You have the left ventricle that's weakened. And if the left ventricle is weak, it really can't push and force the blood from the left ventricle into the arch of the aorta that will eventually pump blood out to all the parts of the body, including the kidneys. So you have decreased blood here. You're going to have decreased cardiac output to the system. Decreased blood, decreased oxygen. Decreased renal blood flow stimulates the renin, angiotensin, aldosterone secretion. So when the kidneys are receiving less blood and less oxygen, you're going to have the renin angiotensin system, which works where renin is going to be released from the kidneys, which will convert angiotensinogen into angiotensin 1. And then angiotensin 1 goes into the lungs, meets up with ACE, and gets converted into angiotensin 2, which increases the blood pressure, tries to push out more blood. So now we're going to get this backup of blood in the pulmonary vein, because what's happening is you have blood that was pumped from the right side. Remember, deoxygenated blood was pumped into the lungs, and now we're trying to drive blood from the lung into the pulmonary vein, bringing oxygenated blood back into the left atrium. But since this is weak and you have the stagnation of blood pooling and pooling and pooling, you're going to get the backflow of blood pumping in back into the lungs. We want it going this way, but now due to the backflow, it's pushing back into the lungs. So you have high pressure in the pulmonary capillary, leading to pulmonary congestion and edema. Okay? Pretty bad stuff. Left-sided coronary heart failure. Again, I'll say it again. Let's look at the natural flow. We have blood coming in through the superior vena cava and inferior vena cava, drives blood into the right atrium. It's deoxygenated blood. Then it empties through the tricuspid valve into the right ventricle. Right ventricle contracts inferior to superior through the pulmonary trunk into the pulmonary arteries. The pulmonary arteries bring deoxygenated blood into the lungs. The lungs oxygenate it and are supposed to drive oxygenated blood into the left atrium, into the left ventricle, pumping through the aortic valve into the arch of the aorta, bringing all the oxygenated blood. But due to the damage to the left ventricle, being that it can't pump it, and this is backing up, you get this backflow from left ventricle into the left atrium, and the blood that was supposed to go from the lungs into the left atrium, it ain't happening. In fact, it's going to backflow. It's going to go left ventricle, regurgitate into the left atrium and push back in this direction, getting all this pulmonary edema. Okay? Let's look at the other side, the right-sided heart failure. This one is this one's dependent edema in the feet, legs, and buttocks, right? So you're going to get fluid in the extremities. Increased pressure in the jugular veins, which leads to distension. So you get jugular vein distension, JVD. You're going to get fluid buildup in all the organs. You're going to get liver is going to be enlarged. The spleen will be enlarged. You got hepatomegaly, splenomegaly. You have digestive disturbances. You have ascites. Ascites is this complication where the fluid accumulates in the peritoneal cavity. This looks like the beer belly. It looks like the guy that's pregnant, but he's not, right? He's got the ascites, all this fluid accumulation. It's marked abdominal distension. With acute right-sided failure, there's flushed face, distended neck veins, you get the distended abdomen, you get headache, there's visual disturbances. So let's take a look at what's happening here. So now you have the right ventricle that's weak. So remember what I said before, you have blood that comes in through the superior vena cava and inferior vena cava into the right atrium. As the pressure builds up, the tricuspid valve opens, and with gravity alone, it goes from superior to inferior into the right ventricle. When the right ventricular pressure builds up, this contracts from inferior to superior. It's supposed to shut the tricuspid and open up the pulmonary semilunar valve. When the pulmonary semilunar valve opens, the deoxygenated blood pumps here into the pulmonary trunk, into the pulmonary arteries, but look what's happening. This is slower. This is blocked. So we start to get this backflow and accumulation back in here. So if the right ventricle weakens and can't empty, there's going to be decreased cardiac output, of course. There's decreased renal blood flow that will stimulate the renin, angiotensin, aldosterone system, of course. You're going to get backup of blood into systemic circulation. So you're going to start to get this backflow of blood and this increased pressure. Instead of the blood coming this way into the right atrium, it's going to backflow and push this way. It's going to backflow and push this way. So you're going to get swollen hands, swollen feet, swollen organs, swollen spleen, liver, feet, legs, right? You get this edema. And sometimes it could be marked with, if you look at the calf and you look at the anterior compartment of the tibia and you push in there, you get what's called pitting edema, where you can push your thumb into the distal tibia and then remove it, and your fingerprint will stay there. That's edema, pitting edema. Okay, so this is a great little chart comparing left-sided heart failure to right-sided heart failure. But I think you have a pretty good understanding from the diagrams that I showed you before. In terms of the diagnostics, X-ray, that will show cardiomegaly. Also, an X-ray can show fluid accumulation in the lungs because at the apex of the lungs, it should be pointed. It's blunt. It looks flat due to the water accumulation that takes place there. Treatment, here it's mostly supportive, right? The underlying problem has to be treated, reducing the workload in the heart, and just always trying to give supportive care. Okay, looks like we're at the tail end here on rheumatic inflammation, infection in the heart, rheumatic fever, infective carditis, and pericarditis. Now, rheumatoid fever and rheumatic heart disease, it's an acute systemic inflammatory condition. It occurs usually between the ages of 5 to 15 years of age and occurs a few weeks after an untreated infection, usually a group A hemolytic strep. The infections could have been in the upper respiratory tract, could have been in the tonsils, the pharynx, or a strep throat. Okay, so rheumatic fever, rheumatic heart disease, untreated infection, usually a group A hemolytic strep. The antibodies to the streptococcus develops and reacts with the connective tissue in the skin, the joints, the brain, and the heart. Rheumatic heart disease is when the scar tissue forms in the heart, and it may be complicated by infective carditis, which we'll get to in a second. So the pathophysiology, right, this can affect the pericarditis, the myocarditis, and the endo, right, the pericardium, myocardium, and endocardium. The endocardium and the valves, they become incompetent heart valves. This is the most common problem. You get verrucae. Verrucae are rows of small vegetations along the outer edge of the valve cusps. And the most common valve to be affected is on the left side. It's the mitral valve, also known as the bicuspid valve. These are the ones that are most commonly affected. And they become stenotic or regurgitant, meaning when the left ventricle contracts, it can push the mitral valve up where you have this propulsion where it kind of pushes upward, and then you get this regurgitation of blood from the left ventricle into the right atrium. So with endocarditis, verrucae, rows of small vegetations, and they affect which valve? Most commonly the mitral valve, causing a regurgitation. Other sites of inflammation with rheumatic fever, the large joints. You can get this erythema marginatum, which is a skin rash with red macules and papules with white centers. You get non-tender subcutaneous nodules, typically on the extensor surface around the joints. And you get these involuntary jerky movements of the face, the arms, the legs, because it starts to invade into the basal nuclei. So you start to get these movement disorders, these tics. So let's look at what ends up happening here with the rheumatic fever. So it's created by this group A beta hemolytic strep. Hopefully you can recover from it. But if not, you get these antibodies that are formed, and you get this antibody collagen reaction. So you start to get an inflamed heart, plus the joints, the skin, and the brain. And in relationship to the heart, it can affect the pericardium, the myocardium, and the endocardium. You can get an accumulation of fluid or effusion around the pericardium. You can get an arrhythmia or dysrhythmia when it attacks the myocardium, which is called myocarditis, or you can get valve damage when it spreads to the endocardium, causing an endocarditis. With all three of these, you start to get scar tissue, and you just get a loss of function of the heart. That is rheumatic heart disease. Typically shown with low-grade fever, leukocytosis, malaise, anorexia, fatigue, increased heart rate, even when you're resting. You can get heart murmurs and acute heart failure from the valve problem or the dysrhythmia or arrhythmia. There'll be elevated serum antibody levels referred to as anti-streptolysin. There are heart function tests and EKG that can be done to diagnose it. To treat it, typically penicillin or these prophylactic antibacterials, as well as aspirin and corticosteroids as anti-inflammatory agents. Okay, let's look at the infective endocarditis. There's basically two types. There's subacute and acute. The subacute is when there's defective heart valves are invaded by an organism with low virulence, such as Streptococcus viridans. And then there's acute, which is normal heart valves are attacked by a highly virulent organism, like Staph aureus. The basic effects. Okay, what we said earlier was the vegetations. Remember the verrucae? The vegetations. These are large, fragile masses of fibrin platelets, and other blood cells and microbes. And these vegetations can break off, forming these infective or septic emboli. Okay, so that's the infective endocarditis, right? These microorganisms attach to the endocardium, and that's where those heart valves are, and they cause the inflammation and vegetation on the cusps of the valves. Remember, it's tricuspid, bicuspid, so vegetations. Factors that predispose to an infection are the presence of abnormal valves in the heart, bacteremia, and just reduced host defenses. Some of the clinical manifestations are going to be low-grade fever, anorexia, splenomegaly, congestive heart failure in severe cases, with acute endocarditis that's sudden and marked onset. You can get these spiked fevers, chills, and drowsy. With the subacute, it's insidious onset. There's increasing fatigue, anorexia, cough, and dyspnea. The diagnosis here is blood culture to identify the causative agent and antimicrobial drugs for several weeks or even IV. With pericarditis, there's acute pericarditis and chronic pericarditis. This may involve simple inflammation of the pericardium. This is where there is effusion or buildup of edema that can develop in the pericardial cavity. It could be serous, could be purulent, or it could be bloody. But either way, there's the swelling of fluid around the pericardial cavity. That will lead to large volumes of swelling or effusion that can compress the heart, and that compression pushing in will impair its function. With chronic pericarditis, that results in the formation of adhesions, right? Gluing, stickiness of it. That too can inhibit and limit heart function. With acute pericarditis, it may be secondary to open heart surgery and MI, rheumatic fever, lupus, cancer, trauma, viral infections. With chronic pericarditis, the fibrous tissue is usually a result of TB or a radiation to the mediastinum. The mediastinum is the space that's deep to the sternum, but anterior to the spine and between both lungs. That's the mediastinum. Inflammation and infection can come from other tissues in the area, such as the lungs. The effusion may also be secondary to hypoproteinemia from the liver or from the kidney. And the clinical manifestations are going to be chest pain, dyspnea, difficulty in breathing, coughing, and tachycardia. And what you'll hear with this pericarditis is what's called a friction rub, which is this grating sound that's heard on auscultation with the stethoscope. If you were to take your hair and rub your hairs on your head together, if your hair is long enough and you can hold it next to your ears and rub that, that's a friction rub. Okay? The effusion, this is when the large volume of fluid accumulates in the pericardial sac, and that leads to the distended veins in the neck, a faint heart sound. Let's see if I can show you where that is. So here's the endocardium, and here in the blue is the pericardial cavity. So we have fluid around the heart that compresses the heart wall. It pushes inward, and when this pericardial fluid is pushing inward, while these chambers are trying to fill up and expand, they just can't. So you can get this backup into the systemic circulation from the right side. You get decreased blood flow to the lungs, and you get decreased output to the body. Okay? And the treatment here is to treat the primary cause of the pericarditis and the aspiration of the fluid from the cavity. You have to try and remove and aspire any of the liquid that's compressing the heart. Okay, that is paracentesis. Okay, let's look at hypertension, peripheral vascular disease, aortic aneurysm. This is actually got your hopes up. This is actually towards the end. Well, like I said, it would be about an hour and 45 minutes. We're at about an hour and a half, so 15 minutes we should be done. Um, so let's take a look at some of these. Let's get back here. So hypertension, which is high blood pressure. It's estimated that 1 in 3 adults have it. 1/3 go undiagnosed. Males have a higher incidence of hypertension, and after menopause, women can catch up with men and pass us. Um, Hypertension, pre-hypertension, 1/3 of the population have a blood pressure in the high normal range. So anything over 120/80 is pre-hypertension. Normal blood pressure should be under 120/80. Okay, 140/90, that's hypertension. It's commonly seen in American Africans. These are higher incidence, and it's known as the silent killer. It's insidious onset with mild to no symptoms. Let's look at primary hypertension, which is essential. This is blood pressure consistently above 140/90. 140 is systolic, 90 is diastolic. Systolic refers to the amount of pressure in the arterial system or in the ventricles at the time of contraction, and 90 refers to the amount of pressure in between the ventricular contraction. Okay, systole over diastole. This systole is contraction, diastole is at rest. So there's increase in our arteriolar vasoconstriction. When the arterioles vasoconstrict, we have high blood pressure. Now, if the kidneys have decreased blood flow, then that creates a reflex of renin-angiotensin pathway to be activated. And that will increase blood pressure even more. So let's take a look here. So we have a drop in blood pressure or a drop in volume. The kidneys produce renin. Look at the first 3 letters of renin, R-E-N, renal, renin. Renin takes what the liver produces, which is angiotensinogen. Remember, anything that ends in -ogen is inactive. So the renin knocks off the -ogen. If you look at angiotensinogen, angio is blood vessel, tensin sounds like tension. So this is going to have to deal with regulating the tension of the blood vessels. Renin knocks off the -ogen. Now we have angiotensin 1. Angiotensin 1 goes into circulation, gets into the lungs where we have ACE, angiotensin converting enzyme, that converts angio 1 into angiotensin 2. And angiotensin 2 has many effects, one of which stimulates aldosterone. Aldosterone is going to allow the body to hold on to sodium chloride. When you hold on to salt, you retain water. When you hold on to salt and water, blood pressure goes up. Angiotensin 2 vasoconstricts, so we take a dilated blood vessel and we constrict it. So we have like a double whammy. We have from decreased blood pressure to increased blood pressure from the vasoconstriction, and aldosterone allows us to retain and reabsorb salt and water, and that too increases blood pressure. Okay, so when we take an ACE inhibitor, we're blocking the lungs. We're blocking this enzyme, so you never go from angiotensin 1 to angiotensin 2, which means you stay in this dilated state and blood pressure goes down. So the primary or essential hypertension, over a long period of time, hypertension can cause damage to the arterial walls. Remember that squamous cell, the simple squamous epithelium, that endothelial layer, the tunica intima or tunica interna, gets damaged. Then the blood vessels become sclerotic, right? Arteriosclerosis, atherosclerosis, sclerotic. And an aneurysm may form. We'll show you what that looks like in a second. It's a weakening of the arterial walls. The blood supply to an involved area becomes obstructed or reduced, and then you get ischemia, necrosis of the tissues. And the area most frequently damaged by hypertension: kidneys, heart, brain, and the eye, the parts of the body that have the smallest blood vessels and that are very metabolically active. Secondary hypertension, okay, this is going to result from a renal or endocrine disease, like a tumor, a benign tumor called a pheochromocytoma. This is a tumor of the adrenal medulla. The underlying problem must be treated to reduce the blood pressure, but secondary hypertension is caused from renal or an endocrine disorder. Okay? So let's see. We have decreased blood flow to the kidneys, and maybe it's coming from some sort of systemic vasoconstriction. Maybe it's coming from some damage to the blood vessels going to the kidney, nephrosclerosis. Maybe it's a diabetic nephropathy, right? The kidneys and the nephrons of the kidneys get damaged because they have the smallest blood vessels. Well, that will increase the renin secretion. And when you increase the renin-aldosterone system, it's eventually angiotensin 1 goes into angiotensin 2, and angiotensin 2 will stimulate aldosterone. So we're going to get a vasoconstriction, which increases the peripheral resistance, which will increase blood pressure. The aldosterone increases blood volume, which increases the blood pressure. Now we have high blood pressure that can damage the retinal blood vessels to the eye, causing blindness. That high pressure in any vessel can damage the tunica interna. It can damage the blood vessels going into the brain, causing stroke. It's going to create increased work of that left ventricle to pump blood, the oxygenated blood. And the domino effect keeps going around and around and around. Okay? So hypertension is a major issue. The incidence typically increases with age. Men affected more frequently than women. Incidence in women, we said, increases after middle age. There are some genetic factors that certainly play a role. Again, you have to consider genetics, but also poor lifestyle habits. So my father died at 44 from hypertension, right? Heart issues. His mother died at 44 from hypertension. Now, I well passed 44, okay? So if it is in my genetics, what controls the genes are the epigenetics. So now we're talking about lifestyle, and we're talking about eating habits, and we're talking about exercise habits, and we're talking about thinking habits, and eating well, thinking well, and moving well all have a very important role in your overall health. So we have to take that lightly when we say, it's genetic. Well, that just means that perhaps there is a genetic predisposition, but what controls them are other behaviors. So is it genetic based, or is it lifestyle that is patterned and passed on generation to generation to generation? So if I thought smoking was normal because I grew up with parents that smoked and I did it, I may not be here lecturing. You follow? So if we start to mimic the same habits that our parents did because that became the norm, then we become a carbon copy or blueprint of them. Or we can learn from them and break the chain and break the bad habits. Okay? And I'd like to think I did that. All right, let's see what else we have. Sodium intake could be a predisposing factor. Excessive alcohol intake, obesity, smoking. These are all precipitating and aggravating factors to hypertension. Frequently, people are asymptomatic in the early stages. Initial signs are very vague, they're nonspecific, maybe a little bit tired, maybe they get a little morning occipital headache or frontal headache, um, but consistently elevated blood pressure under various conditions, that is the primary sign. The treatment, lifestyle changes. If you're sodium sensitive, reduce it. In terms of weight reduction, more muscle mass, less fat mass. Reduction of stress or better tools to handle stress. Diuretics, ACE inhibitors, or the combination of both. Many drugs use the combination of ACE inhibitors and diuretics. When hypertension is uncontrolled, it can affect the brain, causing strokes. It can affect the eyes, retinopathies. It can cause damage to the heart, angina, MIs, congestive heart failure, high blood pressure, and can create nephrosclerosis and chronic kidney disease. Now, peripheral vascular disease, this is any abnormality in the arteries or veins outside of the heart. And atheroma formation was previously discussed earlier on, so we're not going to get much into that, but that is a major cause of peripheral vascular disease. It's increased incidence with diabetes. The most common sites is the abdominal aorta, the carotid artery going to the neck, and the femoral and the iliac arteries. And the way to assess and diagnose it is doing ultrasounds or doing these Doppler studies and any form of arteriography. With peripheral vascular disease, there's going to be increased fatigue and weakness, especially in the legs. When the legs get tired, they call this intermittent claudication. Intermittent claudication is leg pain. It's associated with exercise followed by muscle ischemia, and the legs hurt. There's this tingling, burning, numbness sensation that takes place. The peripheral pulses distal to the occlusion become weak. So the dorsal pedal artery between the first and second digit can become weak. Feeling the iliac pulse may be weak, the popliteal pulse. In men, they can typically get erectile dysfunction if they have poor circulation below the to the lower extremity. Erectile dysfunction is one of the common signs. Appearance of the skin in the feet and the legs, well, you have to look for bluing or any discoloring, marked pallor or cyanosis. If the skin is dry, if there's no hair on the legs, the toenails are thick or any type of fungal thickening there, and they become hard, all signs of poor circulation to the lower leg. The intermittent claudication, I've had a patient just a few weeks ago, and it sounded like this. They can walk a block or two, and then they have to sit and rest. Then they can walk another block, then they have to sit and rest. Not because of shortness of breath, not because of chest pain, just because of intense pain in their lower legs and the burning sensation. That's called intermittent claudication. The treatment is maintain control of your blood glucose levels, watch the body composition, always be aware of cholesterol, and not just cholesterol and LDLs and HDLs, but remember I said you want to look at the oxidized LDLs as well. Platelet inhibitors or anticoagulants are helpful. Be careful of smoking. Remember we said that that's a vasoconstrictor. Increase walking, increase activity, increase exercise, maintain dependent position for legs, improves arterial perfusion, peripheral vasodilators. Observe the skin for any type of breakdown in the skin. You want to make sure there's no fissures or lesions between the toes. That can lead to an infection, and you want to be careful of that redness of the lower leg that feels very hot and swollen. And gangrene can develop, and then, God forbid, you have an amputation that may be required. Aortic aneurysm. This is when you have the dilation and weakening of the arterial wall, and this can happen from a defect in the muscular layer or the tunica musculosa. There could be saccular bulges, fusiform bulges, or dissecting aneurysm. I'll show you what the saccular looks like. That's just the bulging on the wall on the side, whereas a fusiform is circumferential dilation all the way around. When you have a dissecting aneurysm, that develops when there's a tear in the tunica interna of the wall of the blood vessel, and it continues to dissect and separate. This becomes very dangerous. So some of the etiology of the aneurysms are atherosclerosis, trauma, syphilis or other infections, and even congenital defects such as collagen issues. Okay, so here's the fusiform, where you see it's kind of on both sides. It's circumferential like this. Here's saccular on one side. This is due to a thrombus. And then here you can see that you have this aneurysm, but you see the tunica intima is damaged. These squamous cells are damaged. It can push out. Now, if this is in an abdominal aorta, this can actually show up on an x-ray. I picked one of these up earlier in the year where a gentleman was having lower back pain, and he had a little bit of high blood pressure, and before we treated him, I sent him for some x-rays, and on the lateral lumbar, I saw calcification of the abdominal aorta, and this thing was ballooned out more than this. So we sent him right away to the vascular surgeon, and they had to repair it surgically. So sometimes musculoskeletal problems are visceral, and in his case it was based on the case history. Also, some of these can be heard through auscultation. I use a stethoscope all the time, listening to blood vessels and listening for bruits. Also looking for or feeling for pulses. Sometimes you can see the abdomen just pulsing away, or you can see the neck pulsing away. Frequently they're asymptomatic until they become large or they rupture. And the rupture may lead to a moderate bleed and can cause severe hemorrhaging and result in death. These become medical emergencies. Radiographs can pick them up. Ultrasounds, MRIs, CAT scans can all pick these up. In terms of treating it, it's maintaining the blood pressure at normal levels, preventing sudden elevations caused by exertion. So anything that can increase the pressure, lifting something heavy, coughing, hard sneeze, constipation, trying to prevent stress. Otherwise, surgical repairs are going to be necessary. In terms of varicose veins or varicosities, these are irregular, dilated, tortuous areas of superficial veins. These could be seen most commonly in the legs, but they can also occur in the esophagus and the rectum. Varicosities in the legs develop from weakness or a defect in the wall or the valves of the veins. Long periods of standing can increase the pressure within the vein and bring them out. And varicosities can also be a precursor to thrombus formation. There's familial tendency. There's less muscle support in the superficial veins. There could be valvular damage after trauma or an IV administration, or thrombophlebitis, standing for long periods of time, or sitting with your legs crossed for extended periods of time. So here you can see this blood vessel looks normal. It has good, healthy valves. When blood is moving inferior to superior, if it comes back, these valves should stay closed. These are healthy valves. In a varicose vein, as blood comes up, these valves are unhealthy, they're leaky, and they can regurgitate and come back down. And then you get these tortuous looking blood vessels that look like this. These are varicosities. So the superficial varicosities appear irregular, they appear purplish, they're bulging, you get edema, swollen ankles and swollen feet, and the treatment is really keeping the legs elevated and a lot of people wear these support stockings um, to try and assist with the backflow. Restricted clothing and crossing the legs should be avoided. All right, finishing up here with thrombophlebitis and phlebothrombosis. Of these two, the one that's more common is the thrombophlebitis. This is a thrombus that develops in an inflamed vein. Phlebothrombosis is a thrombosis formed spontaneously without prior inflammation. So the factors for the thrombus: stasis of blood or sluggish blood flow. Think of what happens on an airplane. You can be sitting for hours and hours, and people often get a thrombosis. So they'll say, pump your ankles every few minutes. Take a walk on the airplane. Go up and down the aisles at least once an hour to keep the blood circulating. Endothelial injury is another factor for thrombosis, and increased blood coagulability. The clinical manifestations, they often go unnoticed. There's aching, burning, tenderness in the affected leg. The systemic signs are fever, malaise, and leukocytosis, and a complication of it could be a pulmonary embolism. The treatment are preventative measures: exercise, elevate the legs, blood thinners, and when needed, surgical intervention. And as I said, it would be around an hour and 45 minutes. It was pretty darn close, okay? All right. Hope you enjoyed that and study hard.